much of her day drinking in the public park and on the courthouse lawn near our clinic downtown. When she was found unconscious in the alley behind our clinic, I was not only horribly sad, but also not really shocked that she'd ended up in this state and then ended up in the psychiatric facility where she was able to be medically detoxed. For me, though, I wish we had reached Jane sooner. The patient that really has stuck with me as I've worked with SBIRT is not actually Jane, but Diane, who was one of my favorite patients. She was a single mother. She worked full-time. She was well put together, sweet, and soft-spoken. And while her diabetes were frequently not in clinical control, which landed her with me, we knew she was a pack-of-day smoker. And when she got in a car accident, receiving her 5th DUI, which in Montana, unfortunately, is not very uncommon, we had no idea how much she struggled with drinking. I didn't know how much Diane drank, and neither did her primary care provider. She hadn't told us, and we hadn't asked. While her drinking, when we did screen her, did not indicate an actual dependency disorder, it showcased how destructive alcohol misuse can be and how it can affect almost anyone. In implementing universal SBIRT screening, it really becomes clear that we avoid cases like Diane's completely, and we can intervene in cases like Jane's before they escalate. So today I'll provide an overview of SBIRT and its impacts. You can see here we'll give an overview of the model, evidence of how effective it is, example workflows for how you can implement it in your primary care clinic, a very brief overview of how to bill for SBIRT, and some implementation best practices and resources available in the state of Oregon to help implement this effectively. So SBIRT is actually an acronym and not a verb, although I do enjoy sometimes saying I'm SBIRTing. It stands for Screening, Brief Intervention, and Referral to Treatment. The focus on screening and brief intervention is really where the brunt of new skill development and workflow changes are. With RT, or referral to treatment, other than being streamlined and having clear definitions of when referral to treatment is appropriate and for which patients, it remains largely the same on the provider end. How a clinic gets here and then follows up with patients who have been referred is part of the new SBIRT methodology, however. SBIRT often encompasses screening for only alcohol and drugs, but can also, and it commonly does, include tobacco and depression screening. Behavioral health screening need not be limited here either, but can also include domestic violence screening or STI screenings. And although our pilot and much of the research around SBIRT has been focused on drugs, alcohol, depression, and tobacco, because there are evidence-based screening tools that have been vetted by the United States Preventative Service Task Force, and they are recognized and reimbursable through most payers. Many of your clinics may already be using the screening tools we'll talk about today that make up the SBIRT bundle, but perhaps you're not implementing them universally, or you're not screening with them in this bundle of services or providing a structured brief intervention. So why screen? It's a great question, and I think it's one that's important to ask yourself before taking on SBIRT. I'll provide a lot of this data up front and then get into some of the specific tools and workflows that are operationalized to achieve this. And if you have any questions about this data that I don't cover here, or you have any questions throughout the presentation, remember to please type them into the question box so we can address them together at the end. And before discussing why this tool is effective, I wanted to provide this brief overview of the issues that many patients in our healthcare system face, thinking back to the examples I gave earlier of Jane and Diane. So the issue really at hand is that tobacco use, risky drinking, drug use, and depression cost our country about $870 billion a year in healthcare, productivity, and societal costs. So when we think about that, not only are we costing the healthcare a significant amount of funding and money, but we have issues of productivity, people missing work, coming to work late, being hungover under the influence at work, and societal costs to the justice system of car accidents, of violence. Not only that, but patients with chronic illness and untreated substance abuse or mental health disorders are hospitalized 4.2 to 5.7 times more each year than those with the chronic illness alone. We know people with chronic illnesses are using the emergency department and hospital facilities more than we would like them to already. So this is further compounding the use of emergency services and an inappropriate use of them. Probably most shocking to me is that in Oregon currently, only about 0.42% of patients identified as having an alcohol or drug disorder are treated. This evidence comes from a Stanford data study of the patients that were screened and were identified as having a disorder, a substance abuse disorder or dependency that required a medical intervention. These were the percentage of patients who were actually able to or willing to access treatment. So with that being the background, at least in our state, but unfortunately it's not too unique here, many of you being familiar with the triple aim, that really guides why we think screening is so critical. The triple aim, or optimizing healthcare by increasing access, improving outcomes, and decreasing costs, is what SBIRT is all about. When effectively implemented, SBIRT is able to impact all three of these pillars in profound ways. We can see here that after a universal, so meaning every adult patient, SBIRT implementation, clinics see a significant reduction in 7-day alcohol use and the frequency of excessive drinking. We'll talk about the guidelines for low-use drinking, or low-risk drinking, that include the use guidelines for a week and how many in one sitting. Additionally, fewer days of hospitalizations are cited following a universal SBIRT implementation, a $523 reduction in healthcare costs per risky drinking patient, almost $4,400 reduction in total healthcare costs per dual-eligible patient, meaning those who have Medicaid and Medicare, a 20% reduction in binge drinking, so the number of drinks consumed in one sitting or in one day, a 15% reduction in marijuana use, a 55% reduction in depressive symptoms, and interestingly, we also see an increase in patient satisfaction. So not only are we controlling costs and improving patient outcomes, but patients are more engaged with and more satisfied by the quality of care and their health themselves. So here's an overview of the process. We'll get into the actual workflow and the tools in a moment, but this is kind of the 30,000-foot view. You can see here, I hope you can see my arrow here, that we'll start with the annual screening. The annual screening typically involves 3 of those vetted screening tools, a 3-question audit or alcohol screening, 1 to 2 questions on drug use, and 2 questions on mood. If a patient answers yes to any of these initial screening questions, you then provide them with the full screening. So if a patient indicates yes, that they are suffering from a mood issue, you would administer the entire PHQ-9. If a patient indicates yes to all alcohol, drug, and mood questions, all 3 audit, DAST, and PHQ-9 screens would be given. We'll go over these full tools here in a moment. So if a patient responds to these full screens and their response indicates risky or harmful use, but not dependency or severe depression, a brief intervention is performed. So you'll see here, pending these full screen results, they may need just a brief intervention. However, if during this full screening phase a patient response indicates dependence, suicidal ideations, or severe depression, referral to treatment is necessary. So here's another kind of overview of what some of those questions can be like on that annual screening tool. How many times in the past year have you had 5 or more drinks in one day? Or during the past 2 weeks, have you been bothered by little interest or pleasure in doing things? Here's a screenshot on an example of the alcohol questions as part of the annual screening form. For our pilot, we've actually sandwiched these questions with other annual health questions such as exercise, nutrition, and then we move into alcohol, drug, and mood to try to destigmatize the associations that many people have with these screening questions. This is a great example of a health literate and accessible form because we're quantifying here what one drink really means. People are often surprised that one drink is really 12 ounces of domestic beer or 1 shot of liquor, and often when you talk to patients who suffer from drinking harmfully or alcohol dependence, you'll often find that they quantify drinks as per bottle of wine or maybe per pour of liquor, but are not really sure actually how many drinks to these measures that they're consuming. So we'd have here, importantly, men and women have different guidelines on what healthy levels of alcohol consumption are. We'd be asking, how many times in the past year have you had 5 or more drinks in a day? If they said none, that would be a negative score, but if they said 1 or more, that would indicate that they could be a good candidate for the full alcohol use screen, the audit. Importantly with the annual screening results is that when they're given to everybody, even if the patient answers no, it really needs to be followed up with. This is where screening kind of kicks into high gear, and you can see here if the patient answers no to all of the questions, so those detailing mood, alcohol, and drug, that's fantastic. It's really important to congratulate the patient and reinforce those healthy behaviors, and the patient should be rescreened in 12 months. When done universally, you can see with these screenings, they really remove all of the stigma as well as cultural assumptions about what kinds of patients suffer from substance and mental health disorders, as when it was an issue with us previously in my clinical experience with patients like Diane. And just as with the triple aim, we know that social determinants of health have upstream and downstream implications. So we're able to intervene early for patients who may have no risky behaviors or no depressive symptoms, congratulate them, support them, and let them know that we're a good place to turn if they do ever start to suffer from any of those points. Additionally, though, if we have a patient answer yes to any or all of the questions, that's what targets that we know we need to provide a full screening. So here, if a patient answers yes to the mood questions, we would administer the PHQ-9, the audit for the alcohol questions, and the DAFT for the drug questions. So this is for patients who answered yes to the drug questions. You can see here this is 10 questions followed up with a question about injecting drugs. There are both questions about just use in general. Do you abuse more than one drug at a time? And then there are also some of the more socio-symptomatic ones of have you engaged in illegal activities in order to obtain drugs? And trying to connect it to medical and social problems. Have you had medical problems as a result of your drug use? So this would be scored, and there is a scale pending if they answer yes or no or the amount that they're using. We'll put them into one of 4 categories. That would be either low risk, which for DAS is important to know is abstinent. There actually is not a drug use category that is at all clinically able to be supported. So it's either nothing, we'll put them at low risk. So in states that do have decriminalized marijuana, for instance, a patient who did indicate that they were using marijuana socially would still fall into that risky behavior category with this screening. So there is risky, there's harmful, and then there's dependent. This becomes much clearer with the next screening, which is the audit for alcohol use. Here you can see, again, it starts out with questions on just the patterns of alcohol use and then moves into more of those personal and social impacts. So in addition to how often they drink, how much they drink, we're also asking how often during the last year have you had a feeling of guilt or remorse about drinking? How often have you been unable to remember what happened the night before because of your drinking? Has a relative, friend, doctor, or other healthcare worker been concerned about your drinking or suggested you cut down? So again, there's a scoring rubric for this because we know that sometimes people may score very highly on the first few questions, meaning that they drink very frequently or drink in excess, but they don't experience some of these social or cultural impacts that are in the last few questions. This can be an important indication of harmful use versus dependence. And again, for patients who indicate or answered yes to the first couple mood questions, the PHQ-9 is the kind of vetted primary care screen for depression. So in addition to trying to understand the severity of depressive feelings, this also is a screening tool for suicide. Importantly, when you do implement PHQ-9 or any depression screening in your clinic, you need to make sure that you have a protocol for immediately responding to patients who do indicate that they have suicidal ideation. So here's a great tool that was developed by the SBIRT Primary Care Residency Initiative here in Oregon. The Oregon Health and Science University has been working to train all of their residents in SBIRT, so in how to screen for these disorders or use and how to provide brief interventions. I think this is a great tool because it provides a lot of information in one graphic. So here we can see this is the low-risk drinking limit. Men are advised to be at low risk to drink fewer than 14 drinks per week and no more than 14 drinks per day. We'll see women have a much lower low-risk drinking limit, so 7 drinks per week or 3 drinks per day, and all people over the age of 65. Sometimes just showing this to a patient who has scored into the harmful or risky drinking category can be very influential, as they may not know that their drinking patterns are inappropriate or risky, or just how outside of these guidelines their drinking is. You'll also see here the categories of drinking. So low risk with the associated scores. Oops. The associated scores for the audit. Again, that's the alcohol screening. The DAST, again, only a 0, so no drug use at all. We'll put folks into this low-risk category. And here we move into risky and harmful drinking. So this is people who are drinking outside of these low-risk drinking limits or using drugs in a way that indicates that they're not dependent on alcohol or drugs, but they're using at risky or harmful levels. So we see here that this is the brunt of folks who are outside of the low-risk or abstention part of this screening. And this is where the brief intervention is used and targeted. It maintains keeping those patients within your primary care facility, providing the brief intervention, and not inappropriately referring to treatment when it's not required. So kind of why brief interventions? What is a brief intervention? Why are they such an impactful tool? So the goal of brief interventions are really to educate patients and increase their motivation to reduce risky behavior. It's conducted with patients who score, again, into those risky or harmful use categories, but not into the dependent categories. So we did have a couple technological issues where we weren't able to load the videos I wanted to show. So I will just kind of share with you the background of brief interventions with both them as a modality and examples of how a successful brief intervention looks given a more diagnostic-driven intervention with a patient. So brief intervention is grounded in common patient-centered and motivational interviewing techniques, but it's important to note that it's not pure motivational interviewing for those folks who have received training, and that it uses these wonderful open-ended reflective tools, but also always conveys clinical recommendations. So we won't only reflectively listen to patients as they talk about their alcohol and drug use. We'll also let them know, again, what those low-risk guidelines are, but we will do so in a way that supports them to feel motivated to change, rather than having it be only about our recommendation or the clinical guidelines. The first example would have been a video talking about and this, again, is linked directly, as Kate mentioned. The slides will be on the PCPCI website, and you can directly look at this clip. It's an example of a woman who comes in with her infant son because he's had one of a long strain of ear infections. And the provider asks her if she's smoking around the child. And when the mother says that she really tries her hardest, she tries to only smoke outside and not around the baby, the doctor goes into all of the reasons why this is a bad behavior, all of the negative health impacts. You could get emphysema. You're going to, he could get dental cavities. You really need to stop. This is really bad. You're putting yourself at risk. And you can see the patient get very defensive. She wants to be a good mother. She's taking him to the doctor because she wants him to be healthy. She knows it's not great that she smokes, but she doesn't feel empowered to ask for help, and she doesn't feel like she can change. So the second video, or this kind of effective physician here, you can see that freeze frame of them, is after this first, the acknowledgement that she does smoke, really tries hard not to smoke around the child, and says, and I didn't smoke while I was pregnant. I knew that was important. Rather than telling her how much of a negative impact the smoking has on her child and all of the possible negative implications of smoking, the provider says, well, that's great that you quit while you were pregnant. How were you able to do that before? What made you be able to be successful? And so instead of telling the patient what she already knows, which is that smoking isn't a healthy behavior, she tries to find the things the patient has done to be successful and really kind of springboard on that patient's motivation to live a healthy life and to provide a healthy life for her child. So within SBIRT, we kind of use this too when you have those alcohol or drug results, that you go over what the results were, and instead of telling the patient that they need to stop drinking, you start a conversation. What do you think about these results? Or have you ever talked about this before? So it's a way to engage in patients in an open-ended, patient-centered way to help them feel motivated and supported to make behavior change. Importantly, though, if a patient does score into the dependent category, we know that they do need additional and more intensive support in order to stop using. And so there wouldn't be a, can you cut down to this level or that care planning that can happen. For the risky drinking levels, they would need to be referred to treatment. I do definitely encourage you to look up those videos. I think they have a great example of how you can kind of get into that diagnostic dive of knowing all of the reasons why something is a poor health choice and wanting to help this person live a healthier life, but doing so in a way that's supportive. So here with the referral to treatment, so this is for those patients who score into the dependent zone for alcohol or drug use, and they will need to be referred to more specialized treatment. So examples of that treatment, and some facilities may provide this in-house, would be a medication-assisted treatment in primary care, such as Suboxone treatment. So we have several community health centers in Oregon who are able to provide this support to their patients, but many aren't. So for those who don't have that in-house, it may be a referral to an outpatient, inpatient, or detox facility in your community. And it's very important that you have these kind of referral arrangements clarified prior to starting to screen, so you know where you're sending patients, how to call, what the process is, what kind of payers they take, or if patients are uninsured, what their options are. In Oregon, there's also a state resource and crisis line that you can call that helps identify possible sources of care for patients as well as when they're in crisis. And when including depression in your behavioral screening program, it's really critical that I mentioned earlier that you identify an immediate intervention plan for all patients who indicate suicidal ideations on their PHQ-9 results. And for patients whose scores indicate moderate or severe depression, the PCP or the primary care provider can be a treatment source through medication management of antidepressants, or you can be referred to an in-house counselor or community counseling service. For patients where there's suspicion of a mental health diagnosis such as bipolar, additional screening tools exist that can be administered in the primary care setting or, again, through a referral to a mental health practitioner. So now that we've had an overview of kind of the process and the tools, I wanted to give an example of how this workflow can be implemented in a primary care clinic. We're partnering with WellSys, a group out of Madison, Wisconsin, who has received SAMHSA funding to implement SBIRT in around 45 primary care clinics around Wisconsin. We're piloting this screening methodology in 5 of our community health centers here in Oregon. So we can see here again that we'll start with the annual screen. So every adult patient, or however you've defined your target population to begin with, would receive that annual screening when they check in. Typically, the receptionist would hand this form to the patient. An MA would quickly score this annual screening, knowing again that just checking yes or no is how you would score that. So if a patient has checked yes for any of those questions, they would be given a full screen. And in our pilot, we're using what's called a health educator. So a health educator is commonly a non-clinically trained layperson or community health worker who receives substantial training in motivational interviewing, collaborative care, and patient-centered communication to work only on doing behavioral screening, the screenings, the brief interventions, and helping to facilitate the referral to treatment and patient follow-up. So for our model, these health educators will provide that full screening, provide the brief intervention when the scores of the full screening indicate that, or if the full screen indicates a dependency or severe mental health, that health educator would refer to the provider. Importantly, the health educator is not diagnosing outside of those assessments, but they are just doing that baseline assessment. So where a dependency is indicated or there is a need for an actual mental health diagnosis, just those top of the pyramid, those red 5% patients would be referred back to the provider. Another common clinical workflow for SBIRT, though, can be provider-centric. And this can be a more accessible model for primary care clinics who do not have care teams or a lot of ancillary services. So you'd see that it's the same workflow starting with that annual screen and the MA scoring of that screen, but that the full screening and brief intervention would also be completed by the provider. This really can be challenging only because of having to balance that with our current appointment reimbursement system, as the billing for behavioral screenings are often time-based, and we know that providers typically have a lot to cover in their 15 to 20-minute appointments with folks. So I did want to just briefly go over SBIRT billing. This is a very brief overview and in a simplified version. So in Oregon, with SBIRT being one of our coordinated care organization quality and incentive measures, the Oregon health authorities will be providing guidance on how to code and document these screenings appropriately. So this is definitely not the final version, but it's kind of a brief overview of how things work now. So you can see here on the left, again, this was developed by the SBIRT Oregon residency program, that there's the codes for Medicaid, Medicare, and commercial billing, and that they are time-based. So this code, say that you have a patient who comes in who has Medicaid, Oregon health plan in this state, who indicates on that annual screening form that they have consumed more than the 4 drinks that is the low-risk guideline. So they receive an audit, and on that audit, they score into the risky drinking categories. And the health educator or provider does a brief intervention that takes 16 minutes, or between 15 and 30. So this would be the code that you would want to use, because you had done that full screen and provided a brief intervention, and it had lasted between 15 and 30 minutes. If it had lasted more than 30 minutes, you would have had a separate code here to use, the 99409. Medicare, of course, has separate coding requirements, as do the commercial insurers. We are very fortunate in Oregon that many of the payers in this state have worked together to try to align their coding and reimbursement requirements so that folks don't have to be as concerned with the payer when coding this to meet the incentive and quality measures, but also to make sure that more patients are able to access these screenings. One very important question is who can bill? So importantly, there are different, and this is different in every state, incident to billing regulations, which means that there are certain people who can bill directly for these services and certain people who can bill under a provider license for these services. In Oregon, for Medicaid currently, there are very few requirements for incident to billing. So while only a licensed provider and only certain licensed providers can directly bill for these services, it is possible for people like our health educators who are not clinically licensed to provide this service that would be billed within that encounter from the primary care provider. Again, this is all kind of in flux now and a complicated issue, but this is a brief overview of how billing is working currently. And I know there will be a lot more discussion and technical assistance around how to code and document this in Oregon as all of the OHA Scoring and Metrics Committee finalizes how they will incentivize and measure these quality measures. So of course the big question is, well, how do we implement this in our clinic? There's a great saying that if you've seen one community health center, you've seen one community health center, and I think that stands for almost all primary care clinics. They're each really unique. Your workflows are based on who's in the positions, so there can be some great general guidelines, but how you operationalize or implement screening methodologies or any clinical quality improvement project is very unique. So we got together with some of the other training and technical assistance providers of SBIRT and tried to identify some of the kind of high-level critical pieces that we think are important for a successful SBIRT implementation. They're definitely not all required, but we think they make for optimal implementation. You can see we have kind of 4 different categories: engagement, training, implementation, and measurement. For engagement, it's really important that all parties in your organization or clinics know about SBIRT and are engaged in its implementation, starting with executive sponsorship and primary care provider leadership. It's also really critical to have that clinic or mid-manager supervision, kind of the decision makers on the clinical protocol or workflow process involved, as well as the whole care team, so everyone who will be providing this care, if you're going to use the reception to MA to health educator or provider model, and making sure that it's also is aligned well with the goals and strategic plan of your organization, and that you've discussed the financial viability, so how you will code for it, how that will work based on the time required to implement. When you do decide to move forward and have engaged your staff, it's important that you are able to train all of those parties effectively. So these are some of the trainings that we found really critical: motivational interviewing training and collaborative care model overview, as well as screening tool proficiency for whoever will be doing those full screens, as well as the brief interventions. Additionally, it's important for staff to have training on billing for SBIRT, how to document either in an EMR if you're using paper charts, how you'll document that way. Workflow planning and referral mapping. It's really important to have at least an initial idea of what the workflow will look like when you're implementing SBIRT, but also very critical to have ongoing and continuous quality improvement built in with the initial workflow, because it almost never is the workflow that actually ends up working. I know Dr. Rich Brown with the Welch's group said that of all of those 45 clinics that they've worked with in Wisconsin and now with our clinics in Oregon, that there has not been one health center that has continued to use the first workflow that they came up with, but they've all found one that was optimal for them. Again, as we implement, after we've engaged the staff in the SBIRT project and initiated training for the identified staff, it's important to identify the target population for universal screening. So while the goal is that every adult patient who enters the facility would be screened, sometimes you have to start at a pilot phase or start with just a smaller target population. So maybe Dr. Smith's patients will start there, or if you have care team pods, maybe we'll start with the Coast pod, or really determine who is going to be the target population. Again, after designing that initial workflow, assign tasks. So who from each team specifically will be doing each piece? Maybe Brenda is the receptionist who will be giving the initial screen, and Joe is the MA who's going to be screening. So making sure that everybody knows what their role is in this workflow. Again, that rapid cycle improvement of SBIRT is critical. So how often are you going to meet as a team? How are you going to implement changes? Identifying billing policies and procedures. So how do you code it? If you do it in the EMR, what kind of documentation do you need? So making sure that your financial organization, so if you outsource the billing, making sure you're meeting their needs, or if you have in-house billing, you know, what they need to be able to bill appropriately. Really critical for SBIRT is the ability to standardize electronic medical record, or really just medical records. So if you're still on paper charts, you can absolutely do SBIRT. The documentation, though, is very important to be standardized. So not only do we want to know when a patient is due for screening, so if you screen a patient and they had a negative initial screening, so are due for another screening in a year, we want to have a way to track when that patient is due. We also want the results of the screening to be easy to find, whether they were negative or positive, so we can track improvements or just track that it's happened. We want to know what their interaction was with the health educator. Did they come up with a self-management kind of goal? Did they come up with a care plan? Did they have some personal growth that they were going to work on? We want to be able to have that in the chart so that people can both measure progress on those goals, but also work with the patient to optimize the plan and make sure that they are going forward and working together collaboratively. Of course, we want to know when a patient was referred to treatment. We want to know where they were referred, when the referral took place, and the importance of closed-loop referrals is really important with this. So when was a patient able to enter treatment or able to access that specialty mental health care, or if they weren't able to, why not? We need to identify those barriers, whether it's the patient selecting not to, or if they're coming up against system barriers. And again, measurement and reporting. Of course, we have the old saying that what gets measured gets done. We have some measurements or metrics that are commonly used with SBIRT that will be used, many of them in the state of Oregon, and that we're using in our pilot project. So it's important both because we have all of these impacts that we think SBIRT will have on costs, on patient health outcomes, and it's really hard to know if you're achieving the impact that you want if you're not measuring. So those measurements, or this last kind of square over here, is that we want to know of that total target population. So maybe Dr. Smith has a panel of 1,600 patients that are all adults, and 800 of them came in this pilot period project. So we want to know the percent of those patients that were screened for SBIRT, if the goal was to screen all of them. Additionally, we want to know the percent of those positive screens, so patients that both indicated yes on the annual screen and then had a positive audit, DAST, or PHQ-9 that received a brief intervention out of the total positive screens. So we would, of course, love to see this as being 100%. So 100% of people who needed a brief intervention received a brief intervention. Secondly, we'll see that the percent of positive screens that indicated a need for treatment or the specialty mental health care that received a referral. So we're not measuring the percent of those patients who were referred that completed treatment. We're just measuring the percent of those patients indicating the need for treatment who received that referral. And again, one of the very, I think, most impactful measures here is when we're looking at the percent of patients with a reduction in risky behaviors at rescreen. So often PHQ-9 will be re-administered at set variables following a positive score to try to track a reduction in depression symptoms. And we really want to measure that so we can know that the result of a brief intervention, what the impact was. So for folks who may be at many places along this continuum, from this being the first time you've heard about SBIRT to maybe you've been trying to do this for years but want to try something different or optimize, or maybe you just want to know what else other folks are doing. In Oregon, we're lucky to have many resources available to support clinics as they research and implement SBIRT. And as our coordinated care organizations work to define and operationalize SBIRT as a quality measure, the resources are really ever growing. For folks outside of Oregon, SAMHSA is a great resource, as are other regional locations of the Addiction Technology Transfer Care Network, which I'll talk about in a moment up here. All of the screening forms, the videos I mentioned, and links to these websites are available through the PCPCI website of these slides. So the Oregon Primary Care Association here, we're working with our federally qualified health centers in the state to pilot this currently just in 5 health centers, but looking to expand, and always interested in working with and supporting our fellow CHCs who are interested in implementing. The Addiction Technology Transfer Care Network, or ATTC, here is the kind of northwest branch, is located in Portland. And they provide SBIRT training and technical assistance for primary care clinics, behavioral health organizations, as well as government systems. So they have a broader target audience that they work with, and are located at Oregon Health Science University. We also have Jim Winkle, who has worked with that SBIRT Oregon primary care residency program, and he's able to provide a great overview of SBIRT and some of the clinic tool screening forms and videos that he's been able to help primary care clinics implement. Again, the links to all of the SBIRT resources we mentioned will be available at this link, and that includes links to the Oregon SBIRT project to download the audit DAST annual screen, and that clinic tool with the low-risk drinking guidelines, which can be great to get started with. So from here, I know that the folks probably have a lot of questions. SBIRT can seem a little bit overwhelming, or there are a lot of different moving parts. So if you've written into Kate your questions through the question box, if you want to do so now, if you haven't already. And Kate, if you want to let me know if there are specific questions that many people have had, or how I can best be of assistance.
Yeah, so hi Zoe, it's Kate. We did get a couple questions already, and I would continue, or I would ask that people continue to send those in. So the first one was, you mentioned health educators, and there was a question about the educational requirement of a health educator, and if you could speak to that.
Absolutely, that's a great question. This is based on a lot of the work that was done in Wisconsin, so there actually is not an educational requirement. The folks at Wells kind of came up with a job description of what the ideal health educator would have in terms of a background, but largely that they say really the most important trait is empathy, that you think this person has those personality traits to be a great motivational interviewer, but that there isn't really an educational program required to do this work well. I think they found that an ideal candidate may have a bachelor's degree, but they aren't required to, and there's not a specific field. They've just found that that can be a good indication of critical thinking skills. We have health educators, though, in our pilots from folks who have only a high school education all the way up to people who actually are credentialed mental health providers. So we have across the gamut and are really finding that those folks who are more at the community health worker level, so non-clinically trained, but really empathetic and interested in facilitating change, have been really able to move forward because they don't have those billable clinic hour possibilities that mental health providers or clinical staff might have. And in not being like a medical assistant or a nurse, they haven't received any training that might make it harder to change their own behavior in interacting with patients to be more patient-centered and reflective.
Excellent. Thanks for that. And then another question that came in was, what about adolescent screening?
Excellent question. Thank you for jogging my memory on that. I wanted to mention that. So our program is working just with adults, but in our state, the Department of Adolescent Health is working to create an adolescent screening pilot project. So there are definitely tools. The CRAFT tool is used with adolescents specifically and focuses largely on the initial use of alcohol or drugs. So working with adolescents, I believe 12 to 24, I think is how they are defining that in this project, to work with them to screen, again, congratulating, supporting adolescents who have not had that initial use or are not using, and then working to provide brief interventions to adolescents who are. So that's definitely, there are clinical tools to do that. And I can provide Kate with the contact information for the folks at the state who are working on that project in Oregon if people are interested in getting more information about that tool and those training opportunities.
Yeah, people can submit questions right now if they're interested in receiving more information on that. And then there's also a post-session survey where you can indicate, hey, I'd like more information on, this part of the presentation or the adolescent screening tool that Zoe just mentioned. So one of the other questions was about good online resources or online resources you'd recommend related to motivational interviewing. Motivational interviewing's come up a couple of times, and I know we're going to be doing an institute webinar of which motivational interviewing is going to be a component with Zoe's colleague Ariel in September. But beyond that, Zoe, are there other things you want to recommend as far as online resources?
Absolutely. I think the ATTC folks have some great stuff, as does SAMHSA. So I can provide Kate with links to those. Motivational interviewing is a fantastic kind of training opportunity in that it is really accessible for people, and the biggest commitment is to skill development. So we can definitely send out some links to information, and Ariel, my colleague, will also be providing that webinar in September on an overview of motivational interviewing, and there are a lot of different levels of interventions and trainings available to folks nationally on motivational interviewing.
Okay, great. The other, there were a couple of just comments that I would be interested to hear your response to. So one of them was from a clinic that says when they started doing SBIRT, their patients were kind of offended, like when they were handing out the screening tools at the front desk, or just maybe confused or between confused and offended. So can you speak at all to that, how clinics have maybe addressed just the idea of screening with their patients?
Absolutely. I think that space between confused and offended is one of the trickiest ones to respond to. So a big piece of that can be scripting. So having the receptionist have one thing she says to every patient. And sometimes that can just be, our clinic has every patient fill out this form annually. To destigmatize it, not to say your provider wants you to fill out this form, but it is our policy that every patient completes this form. Additionally, it can be really nice to sandwich some of these screenings, particularly on that annual questionnaire, with some of the lesser stigmatizing or less tricky ones, such as how often do you exercise, or fruits and vegetables questions. Questions patients are pretty accustomed to seeing, and then getting into some of the drinking, drug, and depression questions to destigmatize that and have it be part of a larger behavioral screening questionnaire. So really how you package, present, and communicate just that initial screening can help set the tone. For patients who on that initial screen indicate yes or say yes, so they need a further screening, again, a lot of that can just be how the patient is referred to either a health educator or back to the provider. And saying something just like, our clinic is having all of our patients meet with a health educator, or your provider wondered if you'd fill out this form. So just really working on how you script that, and we have some tools on that and some great examples, but it can definitely be hard, particularly without those scripts, and can be uncomfortable if patients push back and say, well, why? Do I have a problem? Because we want to both maintain that kind of motivational interviewing spirit, but also we want to make sure patients don't feel defensive, that they feel supported, and that if they want to change, that they have the support to do so.
Okay, so one question was, on average, how much time does doing this screening add? And that might be hard, but if you could just speak to that a little.
Sure, I think it really depends. So there are a couple different ways the screening can happen, and you can also really have some guidelines on that. So you don't have to say, unfortunately, and this isn't too uncommon, that a patient answers yes to the alcohol, drug, tobacco, and depression questions. You certainly don't need to provide brief interventions for all of those at the same time. Typically, if you can do a severity of the results, so one indicated, well, they have moderate depression, but they are really harmful drinking patterns. So maybe I'll try to make a connection between these things and see what the patient wants to do. So really have the patient be part of that conversation to say, what do you think about this? Or, would you mind talking to me about this? And really seeing what direction the patient wants to go in. The way that billing works in Oregon for most payers is you can have multiple brief interventions that would be reimbursable within 1 year. So you can do multiple brief interventions on different days with the patient too. So if you have them come back, say in a month to discuss progress too, that could be billed the same way.
Okay, and then we'll probably have time for maybe this one last question, and then maybe one more if anyone else has one. But so the question was around, or I think it was a comment / maybe question that Zoe could speak to. I think people are concerned about what to do as far as if you identify these behaviors in a patient, or there's some concern about referral relationships. So if you can just talk about how practices that you know of have thought about that as they decide to screen, so that there is some places for them to refer people if, as part of the screening process. You can talk about that.
Absolutely, and I think that, that's a really important thing to consider, because we don't want to screen patients if we have nowhere to send them. So we need to make sure we know what we're going to do if patients do respond in a way that requires a referral. One thing that makes SBIRT so impactful is that it becomes evident that we have a vast number of patients who we may not have known were using at risky or harmful levels, but we may have assumed required specialized treatment who don't. So SBIRT is a good way to also catch those people in the risky and harmful levels who may have traditionally been referred but could be retained in-house through that brief intervention. So prior to implementing, I would say absolutely have those very open, transparent conversations with your referral sources. If you don't know who in your community would be a referral source, that state hotline can be a great option, and just making sure that you're monitoring those relationships, because we certainly don't want to have a patient who's motivated to access treatment not have any place to go, or have the place that they've been referred be unable to assist them. So I think part of that is prior to screening, getting that framework established, and also the kind of wherewithal to know that oftentimes when implemented, it is surprising that the the number of patients who score positively on these screenings but do not score into the dependent category, so who can be retained in the primary care facility, or those who do on a PHQ-9 score moderate to severe depression, who are able to be cared for through medication management by a primary care provider or through a referral to a community counselor, which are typically easier to get than to like a outpatient or inpatient chemical dependency program. But I think that's a great question, and I'm happy to answer more questions or follow-up questions or more in-depth questions too if folks have them on that same vein after the webinar.
Okay, this is Kate. I think we're going to wrap now, but I think the one other thing that I wanted to mention is there is going to be a survey after this presentation, and so if you could answer a couple questions about your experience on the webinar today, it helps us at the Institute when we think about additional webinar presentations. The webinar materials can be retrieved from our website, and there's a link there. And again, like I said, it will be also emailed out. A link will be emailed out to everyone who's on the webinar today. You can send additional questions to us via email to that email address right there, or like I said before, one of the survey questions asks about your additional questions. We will forward those to Zoe and get back to you with some answers, some links, some information or resources, whatever is most appropriate. And then I think, as far as webinars go, you can register for, upcoming webinars, and one of them, like we've said, is on patient-centered communication, which really ties in very well to a lot of what Zoe was talking about today. So I think that with that we'll conclude the webinar. Thanks a lot to Zoe for coming and sharing so much knowledge and experience with us, and we look forward to getting your survey results and questions.
Thanks all.
Thanks, Zoe.